हेलो दोस्तों, आज हम बात करने जा रहे हैं हेमरेज एंड इट्स मैनेजमेंट के बारे में। सो कमिंग टू द टाइप्स ऑफ हेमरेजेस, देर आर 3 टाइप्स: प्राइमरी हेमरेज, reactionary hemorrhage and secondary hemorrhage. Primary hemorrhage, it occurs immediately after the surgery. Reactionary hemorrhage, it occurs within 24 hours. This can occur because of dislodgement of the clot by resuscitation or the slippage of the knot. Then coming to the secondary hemorrhage, it is due to the clogging of wall of the vessel, which can be precipitated by infections, pressure necrosis, and malignancies. Now, coming to the degree of hemorrhages. So, based on the amount of blood loss, the hemorrhage is classified into 4 classes. Class 1, less than 15% of blood loss. Class 2 is between 15 to 30% of blood loss. Class 3 is between 30 to 40%, and class 4 is greater than 40%. Now coming to revealed and concealed hemorrhages. Revealed hemorrhage means external hemorrhage. Examples: open arterial wounds, massive hematemesis from duodenal ulcer. Concealed hemorrhage, it is seen within the body cavities. It is of 2 types: trauma induced and non-traumatic. The trauma induced, blood collects in the chest, abdomen, and pelvis, in limbs in cases of long bone fractures. Non-traumatic, it is because of occult GI bleeding and ruptured aortic aneurysms. Now coming to the hemorrhage management in the cases of active bleeding. So hemorrhage or blood loss will lead to hemorrhagic shock. So patient in the state of active bleeding should be aimed to stop bleeding first, and when the bleeding stops, the shock state should be corrected by fluid therapy. So once again, when the patient is in active bleeding, first management should be to control the bleeding, and then the shock state should be managed. To stop active bleeding and achieve rapid hemostasis and maintain the ability of a blood to clot, damage control resuscitation is done. Damage control resuscitation should be done. So this includes 4 things: rapid hemorrhagic control, permissive hypotension, avoid dilutional coagulopathies, and treat existing coagulation defects by giving tranexamic acid, platelets, and fibrinogens. So in the rapid hemorrhagic control, there is damage control surgery. This damage control surgery is done to prioritize rapid bleeding control. It helps to arrest bleeding, control sepsis, and limit tissue damage. Here, the surgical intervention is only aimed to stop bleeding. No definitive repair or procedure is carried out. Thank you.